Intensity-modulated radiotherapy, abbreviated to IMRT, is a highly technical form of radiation treatment. The main purpose of IMRT is it allows us to irradiate cancer tumours within patients, but at the same time reduce the dose to some of the organs near the tumour. And if that organ is subject to radiation damage, it's been shown to reduce the side effects of treatment, and that is been shown in 2 or 3 randomized trials now in head and neck cancer already. So the DARS study is a randomized phase 3 trial. It aims to try to reduce swallowing problems after radiotherapy treatment. So throat cancers occur in about 130,000 people per year globally, and the radiotherapy is the commonest form of treatment. The majority of patients who undergo that treatment will be cured of their cancer, but the radiation that's delivered to treat the cancer will often leave them with swallowing problems thereafter, and some degree of swallowing problem is reported in about 70% of people after radiotherapy with standard treatments. We took the view that the cause of the swallowing problems was the unnecessary delivery of radiation to some of the muscles that control swallowing, which are close to the tumour. And we designed with scientists from the Institute of Cancer Research a way using IMRT to reduce the dose to those muscles, and thereby we hoped that we could improve swallowing after treatment. So we worked closely with speech and language therapists and people in radiation oncology. We performed a randomized trial of 112 patients. Half the patients had standard IMRT and half had this dysphagia-optimised IMRT designed to reduce long-term swallowing function. The patients had tumours of the oropharynx, and the vast majority of the patients had chemotherapy and radiation as their main treatment. The ASCO report is the first report of the outcomes of this trial at patients at 12 months after finishing treatment. And we did demonstrate that a reduction of the radiation dose to these muscles was possible in the experimental treatment arm. The primary endpoint of the study was a questionnaire study called the MDADI. It's the MD Anderson Dysphagia Inventory. We found that in patients who'd had the dysphagia-optimised IMRT, the new treatment, that the swallowing complications was about 8 points lower compared to standard IMRT, and this is the first time that's been seen. We had a number of other patient-reported outcomes in the trial, most important of which is probably the patients who reported that their swallow recovered back to normal after radiation. So in the patients treated with standard IMRT, the current gold standard of care, only about 15% of patients said their recovery was back to normal again. About 85% had some form of abnormality after treatment at a year. Whereas with the new IMRT, which we've been testing, about 40% of people reported that their swallowing returned to normal. So it's a very big difference of an improvement of 25 percentage points in the proportion of patients returning to normal. One of the key things is about safety of the study, and we looked at the proportion of patients who ended up cured of their throat cancer, and it was just the same in the 2 arms of the study. And the side effects were also similar, apart from this reduction in swallowing, which we observed. We've been asked about what are the steps that people need to take to implement this treatment. Mostly those are steps which are done during the radiotherapy treatment planning process. So it will take a radiation oncologist like me about another 30 to 60 minutes to identify these particular muscles and to avoid them with the radiation treatment. And medical physicists who do the planning and the calculation of the radiation dose, it will take about another hour to hour and a half of their time to give each individual patient this benefit in the long term. In terms of future directions, we think that there may be further ability to reduce the dose to these muscles a bit further to improve swallowing recovery, maybe up to greater than 50% of patients getting the benefit for this treatment, and that will be the subject of future work. So far, from the feedback we've had from the treating centres and from other people who've seen this data, it is looking as if people feel that this data is a major step forward in head and neck radiotherapy. I've had comments from people fed back to me in the US and in Europe saying they would like to adopt this as part of their standard treatment. Clearly, the 22 centres that took part in the study in the UK have already got some experience in delivering this treatment and have treated patients in the trial, so they will be able to get the treatments started for their patients straight away. And we think that because the cost and the changes required to move from standard radiotherapy with IMRT to the dysphagia-optimised technique, is really a matter of time spent by the radiation oncologists and the physicists. It should be fairly straightforward for people to implement once they understand the technique.